Hello, everyone, and thank you for the invitation to come to conferences. I always like coming to conferences because I know firsthand the amount of work that goes into putting them together. So congratulations to you all for this successful conference. So before I start, I'd just like to acknowledge the traditional owners of the lands on which we are, the Wurundjeri people of the Kulin Nation, and pay respect to their elders past, present and emerging. So you've heard a little bit about me, but the conference organisers have been very generous with my time, so I might be a bit indulgent and tell you a little bit more about myself, and then I will talk about Rare Voices Australia. So yes, I am the CEO at RVA, which we say for short, and I know in rare disease we're very good at abbreviating, so I know you'll be fine with that. So yes, I am the CEO at RVA, but I also have an adult son, Sean, who lives with a rare disease. And in fact, my very first experience of systemic advocacy was simply as a rare disease mum when my son was about 8. He was starting to deteriorate, and there was a treatment available overseas, but not in Australia. And as a rare disease mum, I had no understanding about why that was the case. And often in rare disease, I think naivety can work in our favour. And I rang the pharmaceutical company and said, "When is it coming?" And this will show you my naivety, because they said, it's got to go through all these hurdles. They said a whole lot of letters which I didn't understand about PBAC, TGA, all these things I really had no idea about at the time. And they said, if all goes to plan, 18 months. And this will show you how naive I was, because I thought 18 months was a very long time. And I said to them, how can I make it quicker? And they said, lobby government. So long story short, as a rare disease mum, I quit my part-time job, and that's what I did, not really knowing what I was doing, but pretty sure I was pretty good at figuring things out as I went along, and thought, well, it can't do any harm, can it? I asked lots of questions. There were lots of people that helped me, but a lot of it was just trial and error. So trying one approach, if that didn't work, would try something else. But what I learned is that effective systemic advocacy actually does change things, and my son was able to access that treatment in 9 months. So what I learned is that even through trial and error and listening to others' experience, we can actually make a big difference, and it can work. So effective advocacy works. So that's probably where I got the bug for advocacy and systemic advocacy. Let's see if that works. No.
Right, I'll do it.
Thank you. No. No. Yep. Okay. So let me tell you a bit more about Rare Voices Australia. So we are the peak body for Australians living with a rare disease, and we work in partnership as the peak body with all the relevant stakeholder groups. So that includes clinicians, researchers, governments, pharmaceutical industries, companies, but most importantly, we work with our RVA partners. So they're disease-specific, consumer or patient-led organisations such as the Australian NPC Disease Foundation. And what we aim to do is to build the capacity of the rare disease community through key projects such as education and mentorship. So up there you'll see our vision and mission, and how one of the key ways in which we demonstrate that. And this is also a project that you guys have been involved in. We run the Rare Portal, and the Rare Portal is a digital library with rare disease information, services and resources, and it's customised for the Australian context. And that's a real gap, because for those that I know, many of you will have gone and search the internet for information. A lot of it is based overseas. But what I think is really exciting about the RARE portal is that the information, the pages on specific diseases are co-designed with the community that actually lives with those diseases. And I'd like to thank you guys, the organisation, for actually working with us to co-design the NPC page. I think it gives it a real strength and a real, a way to share everyone's expertise. So that's one of our key projects. Oh, that's okay, I can stay there. Yep. Okay, the other part of the RARE portal, I think, which is also probably a new program, is the RARE helpline. And this is I guess, a service navigation service, really, and it's staffed by appropriately trained staff at RVA, and it helps to provide timely access to information and answer key questions. And of course, one of the key referral places that we send people to are to the strong patient organisations such as yours. Okay. So next we have the action plan slide, and just to show you that it's real, I brought one. I think I just carry them around all the time. Very proud of this. As I said, the RVA's key focus is systemic advocacy and influencing policy. And our greatest achievement in recent times was that on behalf of the Australian government, RVA led the collaborative development of the National Strategic Action Plan for Rare Diseases, and it had multi-stakeholder input, and it was very much developed by the sector for the sector. And what we have consistently said is that implementation of the action plan is the responsibility of the whole sector, so everyone can contribute to that progress. And what we've tried to do since the launch of that action plan at RVA is done what we can to actually keep track of implementation and to help progress it. What we knew with the action plan is that it needed to be comprehensive and it needed to be meaningful for the long term. But it also needed to be simple enough to be summarised in a plan on a page. And there's an extract of the plan on a page in this slide, and you can see that there are 3 interrelated pillars in words that are quite understandable for all. So awareness and education, care and support, research and data. So I think when we put together the action plan, and once again, I think naivety is useful, because I think if I knew how hard it was, we probably wouldn't have given it a go, but we did. But also, I think I didn't fully understand the power of this policy document. And it is really powerful. Next slide, thanks, sorry. And one of the reasons why it's so powerful is technically it's government policy. And that Australian government logo on there, although the sector did all the work, has been really important, and it's given it a real level of credibility. It is a policy that has bipartisan support, so all parties supported it. And it has led to that politicians and bureaucrats have a greater awareness of this policy document, because it is a government document. And I think that's been really useful for the sector, because although, individually rare diseases have really difficult names to remember and politicians might not have an understanding, if you can frame it within a rare disease, they go, oh yeah, rare disease we know something about, so that's good. It helps give us as a sector a shared language and a common voice. And the action plan is powerful because it responds to those broad range of rare disease issues and those common challenges. It also has a strong evidence base. And I think some of the other benefits that we didn't anticipate with the launch, and I still get excited about it, researchers have started to reference the action plan when they put in research applications. We have seen the action plan be referenced in journal articles, in academic articles. And one of the things, I guess one of the biggest learnings for me is that one of the strongest ways to influence, or one of the things that influence government policy is actually government policy. So once again, this is government policy with the Australian logo there. And what we've seen is that with key policy reviews in recent times, like recently they've reviewed the National Medicines Policy. As part of that process, the government specifically called out for alignment to the National Strategic Action Plan for Rare Diseases. Other things that we've seen since the launch of the action plan has been rare disease flagships developed from different hospitals and research institutions. And we've also seen the organic growth of centres of expertise. And so that's really exciting that policy has driven that, and not necessarily with any new investment. Okay. So I was asked to share advocacy learnings, and if you haven't figured it out, advocacy is a bit of a passion of mine. And this is one of my slides. It's not very clear, the picture, but it is an iceberg. And I always say that advocacy is like an iceberg. So if you think about an iceberg, on the top of the surface, we actually only see a small part of the iceberg, and really the big part of the iceberg is underneath, that's less public, that we can't see. And that bit, that bottom bit under the water, or the submerged part of the iceberg, to me, is research. Because often when we think of advocacy, we think of people, all the loud bits of advocacy, people writing angry letters, or people picketing, or people, you know, protesting. And that can be part of advocacy and is part of advocacy. But the first steps or stages in advocacy is research. We need to do a whole lot of work before we get to that public stage. We need to do a whole lot of work in that iceberg, for that part of the iceberg underneath the water. And so the first thing when I say research is that we have to find answers to questions. And these are some of the key questions that for any advocacy issue, we wouldn't start advocating on an issue until we knew the answers to these questions. It's so important that we are informed, because advocacy is not just about highlighting need. It's about coming up and suggesting potential solutions that have a chance of working. So to make sure our advocacy is strategic, targeted and credible, these are the questions. Who is responsible for or has influence over this issue? And what is the best way to get access to or engage them? And often, you know, we say these to all our RVA partners. RVA has already got often existing good working relationships with a range of governments at a range of different levels. And, you know, if you've made the clever choice to partner with us, make sure that you use us. And we can often set up, and we have often set up meetings for individual organisations. Are there any relevant policies, frameworks, legislations I need to be aware of? It's really important. Governments really like to follow precedent and have some and processes. And I think often in advocacy, we tend to come from the stance of what we think is fair or right. And while that might be right, it's not always effective. What information or use the action plan. The action plan has a lot of policy things that we can use for our advantage. So do use it. It's your plan. What information or evidence can I provide? And then this is a really important one. Who is the most appropriate person or people or group to make the first approach? So sometimes it's not just about having the right message, it's also having the person who has the influence or who could be most influential in giving that message. And sometimes when you think about that, it's actually not just one person, but a coming together of different stakeholders. So if you think about even today, bringing together all the different stakeholders, there's a real power to that, and there's a real credibility that is hard to argue against. So consider doing things like that when there's issues. And the other thing is that we're all very time poor. Is there anyone already advocating on this issue? Can you work with them, share the load? Or can you just learn from some of the things that aren't working for them? Again, what are some of the potential barriers and objectives? Okay, next slide, thanks. So that's a bit about what we would do. But I do have to recognise that an RVA has probably a particular advocacy style, but there are many different advocacy styles. Because we've been doing this for a while, there's probably some learnings that we think some styles are perhaps more effective and some styles are less effective, at least based on our experience. The first one is, I think, the importance of polite persistence. Rare disease, changing anything in rare disease is hard. It's very rare that you will do it in your first go. So you're going to have to be able to keep coming back and encourage people to problem solve with you step by step. So it's useful not to put them offside by yelling at them at the very first, step. So polite persistence is really important. Thank people for coming along and listening. Thank you for people for suggesting a next step. You want to be able to keep going back to them. I did have someone say to me, though, once that, well, you know, if RVA, I know RVA has to be very polite, but we can go and do the angry stuff. And I did say to them, publicly we are polite, but we also foster relationships which can get us behind the closed doors. And in those behind the closed doors, we have most definitely have very robust conversations. We need to be solution focused and pragmatic, because in rare disease, who has time not to be? We have to do things that work. We have to focus on what works, not just what is right, and we have to find what fits within those things. We need to be collaborative. We need to develop relationships, because one of the first things I think I learnt about rare disease advocacy is that there is not one person that has all the power that can make the change that you want to happen. You are going to have to find people to work together, and you need people to work together for change. I think one of the most important things is patient organisations. And certainly we're very protective of this at RVA, which is at the heart of it, patient or person-centred. That gives us a credibility and an authenticity that is difficult for people to ignore. So we need to remain independent. We need to be mindful that all our other stakeholders, although there might be lots of commonality, will have different perspectives and different motives. And we have to be really mindful of that, particularly, for example, for stakeholders like the pharmaceutical companies. There are lots of commonalities, but you really need to go in with your eyes open. We need to engage with all stakeholders. If there's a solution that works for one group of stakeholder, it's not going to be effective unless it works for everybody. We need to be credible. We need to be measured. I am mostly measured 90% of the time. Occasionally I will lose it, but very occasionally. And the good thing with your patient hat on is that if you don't do it too often, you can just say, you know, it's the rare disease mum in me. It's very emotional, and you can pull yourself back. So, you know, and you have to understand the policy and systems. There is no point asking for a solution that there is no precedent for, because it's unlikely to work. So you need to be creative and use what is there. And it needs to be targeted to decision makers. You need to know what the role of the decision maker and the scope of their influence. There is no point asking them for something that goes outside their scope. Okay, so on the other side, limited effectiveness. And when I say limited, sometimes this does work. I have seen many a very angry, critical headline that does seem to bring about a change. But what I would say is that for a rare disease community, for a rare disease organisation, we know that it's not just one issue that we need to change. And you also need to know that the same decision makers that might change on one issue will also be the ones you have to go back to about other issues. So you might get a short-term win, but you might also burn your bridges for later wins. And I think particularly, you know, and I know that this is a really strong patient organisation, understands that we're actually working for patients now and members now, but also for the future members as well. So, limited effectiveness. Those that are angry, aggressive or ambush, that we do go to the media, but it's a very last step. So There's very hard to come back from media, so just be careful about that. What's also limited is those that damage relationships, that is adversarial, dismissive, that is seen to be perhaps in cahoots. I thought maybe I'm showing my age. It sounds a really old term, doesn't it? But often we see that in terms of pharma as well. And rightly or wrongly, there is often a perception in government that patient groups are unduly influenced by pharma. So you don't want your patient voice to be dismissed because it's considered, oh, you're just working with pharma. So just be a bit careful. Again, what is less effective is those unlikely simplistic solutions with no precedence, as I've said. And often, and we've seen this recently on another issue around advocacy around newborn screening, often what is less effective is when the facts or the messaging are not quite right or they're exaggerated. Okay, next slide, thanks. Okay, and so here are some other considerations. And I also wanted to say that from RVA's perspective, we work with over 100 different rare disease RVA partners, and all these groups, of course, have different levels of expertise and experience and resources. But I did also want to give a call out to your organisation as being one that, from RVA's experience, is working really well for its members. But other considerations, I guess, around advocacy is that policy reform often requires robust conversations. So to be able to have those robust conversations, you need to develop those relationships, and that includes utilising RVA's relationships as well. Those robust conversations, particularly if they're political, need to take place behind closed doors. So what I know from RVA is that politicians know that we will give them a credible perspective, and they know that we won't always agree with them, and they know that we will take them to task, but they know we won't do it publicly, and we will not publicly put them in a bad position, but they most definitely know that if they do something stupid, that we will have a meeting with them and tell them that behind closed doors. And that's really important. The other consideration is to really protect your credibility. So you have a credibility from that patient perspective, but that's not enough. You can't just have the emotion of that. You need to have an understanding. And we've got on that slide the importance of RVA's credibility, but you could substitute NPCD Foundation there as well for the same. We need clear, aligned messaging, and it's everything in rare disease is time critical. So we have to do the solutions are most likely to work. And at RVA, that's some of what our discussions are. We'll go, well, what is the right thing to do here? And then the next question is, what is most likely to work? And then you work sort of with a Venn diagram around there. We need to be pragmatic, we need to be strategic, and you need to maintain traction and celebrate the little wins because, gosh, they're important. They're really important. And again, just a reminder that we also need to consider the needs of the community now and in the future. That's really, that's really important. So I might stop there. I don't know how I went with time, and I don't know if people want questions. Yep.
Did we have any questions at all? First of all, thank you, Nicole.
Oh, no, that's all right.
Absolutely amazing and wonderful information. And I think probably the people, Mandy and Dean, a few others kind of know what goes on behind the scenes, but it's really important for people to understand from the outside, it looks like it's ineffective and a snail's pace, but on the inside, it's all hitting the ground running and all working together to get a common outcome. Do we have any questions from, yes, can I get a microphone to Ali, please?
Working, I can just speak loud.
That's on.
Is this one working? Yay,
Yeah.
awesome. Hi, Nicole. I'm Ellie. I'm working on the ANPDF's guidelines of care. I understand that you, all Rare Voices, have released their own recommendations. I was wondering if you were able to speak a little bit about that, and if you think that it will be something that could be utilised in the development of individual rare disease guidelines as rationale or other.
Yeah, sure. So we've done some work as part of a consortium, really, that's led by the University of New South Wales. And it's called the Rarest Project. The Rare Helpline that I spoke about was one component of it, but then another component was around clinical education. And one of the outputs of that project was, as you've said, a national, I always get the name wrong, sorry, National Recommendations for Rare Disease Healthcare, I think it is. And really that work, that's really, I guess, overarching rare disease guidelines that we hope will make it easier for individual disease care guidelines. I think what we know, what I think everybody knows, it's not is around to get real consistency of care and the best quality of care. Care guidelines are really important. Very few rare diseases have them. And I guess what we thought as part of the project, how can we, help bridge that a little bit, or at least give, I guess a bit of an overarching framework for those to come. The other key, I think, advocacy really push at the moment for RVA is around centres of expertise. I think politically, there seems to be an increased audience or a willingness to hear that. What we saw with the action plan is that sort of initial government investment was very much around awareness and education, which of course is very important. But what we're seeing then is it's not translating into being embedded within those systems. So I think the government are sort of starting to see that. And I think if we can develop those vehicles or those, I guess, models of care, such as centres of expertise, those things like developing care guidelines will be much better resourced and able to happen. So as I said, the rare disease recommendations were only ever meant to be sort of a broad framework, but we do hope that it helps with those.
I do have a second question. So with the development of our guidelines, I guess I really want to make sure that it's getting into the places where people are making, you kind of said the decision makers, and in this case, it would be the healthcare professionals like pediatricians or GPs. I want to make sure these guidelines get where it's needed. And a lot of the cases I know that people won't understand, they won't necessarily go to the GP that will understand what the condition is. So hopefully we can make it as available as possible so families can download it and hand it over to their GP. But in terms of advocacy, in terms of actually trying to get it into the right hands, what would you recommend? So for rare disease, I guess you can try and get into these spaces, but how would you actually disseminate the report or even just the summary? How do you recommend getting into those spaces where it's needed?
Yeah, so I think one of the key things, which I'm sure you've probably already done, is actually involving those key groups in the design of those resources. And really, I guess what you're looking for is those champions, rare disease champions, to go and champion out in their networks. One of the greatest strengths in rare disease, I think there are a lot of champions in the whole range of multi-stakeholders. So that would be my first thing. People are more likely to champion something if they feel like a connection to it or feel like that they own it. The other thing I would say, I mean, and obviously if there's some sort of formal endorsement process or something that you can use. And, you know, as part of that, if you can show the alignment between the recommendation, the rare disease recommendations, which is funded by government, you sort of just need to show that sort of sense of credibility, I think, which will help. The other thing which I would not discount is just the power of having something tangible that you can give people, your members, something in the hand that they can go, look what I've got. I mean, that's the reason why I always take this around, because I don't know, maybe it's just because I'm old, but there's actually something that, you know, that gives you a bit of authority. So what a great way to empower, you know, families and patients to say, this is what we've got. Let's work together. This will help you. One of the things that we found with the Rarest Project and around that sort of clinical education is that there is generally a real willingness from clinicians and GPs that they want to do the best care by their patients. They're just not sure. They're feeling under-resourced. So what a great way to resource them. So do use your community to push it.
I will. Thank you.
Are there any other questions from the floor? Any other questions online?
And you can come and see me if it's a bit daunting to ask the question here. That's all right. You can have a chat later. Thank you.
Thank you so much.